Good afternoon and welcome. My name is Tim Poe. I'm the Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, June 14th, 2017, for our UNC Cancer Network RN and Allied Telehealth Lecture. Let's see, a few things before we get started and meet our guests. If you have any trouble, you can call us at 919-445-1000. If it seems like something technically isn't quite right, that'll ring all of our phones, and we'll do everything we can to assist you. Remember that we've got lots of different ways that you can join us. We've got WebEx, we've got GoToWebinar, we've got for the folks with video conferencing, we have the video conferencing units, and then we have the live stream. And if nothing else is working quite the way you want it, the live stream is a great backup for that. You can join us via Poll Everywhere, and we'll talk more about that in a minute. And you can find us on the web at unccn.org. We're on Facebook, we're on Twitter, we're on YouTube, so lots of ways to find us and learn more about all the programs that we have. All right, so we're going to start off with a poll. And we use Poll Everywhere for this. If you've never used it before, you start by texting the letters UNCCN to the number 22333. So on your phone, you go 22333, then you go UNCCN. That's what you send. You do that one time. It tells you you're joined for the Poll Everywhere session. You can also go to pollev.com/UNCCN and do this from a computer or a smartphone. That will work as well. Once you've joined Poll Everywhere, and I hope that you do, then you can go ahead and answer our poll for today. So goals of successful patient navigation programs include, and then you can pick A, B, C, or D. A would be a coordinated team-based approach to cancer care. B would be reducing disparities in access to cancer care. C would be provision of quality medical and psychosocial care from pre-diagnosis through all phases of the cancer experience, or D is all of the above. So you pick the one that's correct. We're going to introduce our guests, and then we'll come back in a couple of minutes and look at that. And then just as importantly, at the end of our presentation, there'll be some time for questions and answers. Once you've joined Poll Everywhere once, then you can come back in and text any questions to us with that same session, and we'll get those, and our guests will do their best to answer those questions later in the presentation. All right, so let me shift something real quick here. All right, and we have our guests with us. Welcome, Amy. Welcome, Jacqueline. We're so glad to have you both with us here today.
Thank you.
Amy Depew, right to my left, is a breast cancer nurse navigator at the North Carolina Cancer Hospital at UNC Chapel Hill. She has served in this role for over 6 years. As a nurse navigator, Amy is responsible for working directly with patients to ensure their journey before, during, and after the cancer experience is as smooth as possible. In 2013, Amy received the Nursing Recognition Award from UNC Hospitals and the UNC School of Medicine for her leadership, diligence, and unwavering dedication to patient care and happiness. So, Amy, welcome.
Thank you.
Jacqueline Webb is also a breast cancer nurse navigator at the North Carolina Cancer Hospital at UNC Chapel Hill. She has worked in medical oncology for over 6 years. In addition to her current role as a nurse navigator, Jacqueline's past experience includes service as a bedside nurse and various leadership and educational roles within her department, including preceptor and charge nurse. Jacqueline, welcome.
Thank you.
So while we're waiting for our poll results to come in, and wow, I think we're trending here on D. That we'll let you answer which one's correct here in a minute. Usually I warn people ahead of time I'm going to ask a question, and I didn't, so I'll spring it on you now. But first, Amy, for you, what led to your interest in nurse navigation and specifically breast cancer navigation?
So when I started nursing, the only thing that I ever really wanted to do was oncology nursing. Mm-hmm. And the more I worked with oncologists, surgeons, patients in particular, the more I realized that we were not attending the needs of the patient or the patient's families or the caregivers. I could give you several examples of what ultimately made me start speaking up. And this was back in a time when nobody even heard of navigation. So eventually, as things do, things started rolling out, and I found out that UNC was actually one of the leaders in developing this program. So I packed my bags and I came over here, and I haven't looked back. This has been a phenomenal role for nursing, and I'm really, really happy to be here.
Well, we're very fortunate to have you. And Jacqueline, what about you?
All of my nursing experience has been in oncology, and oncology patients have been dear to my heart. And in my experience on the inpatient side, I loved the education part of my job and just helping patients know what to expect when they go home, and that piece of it. And just was very interested that where I worked previously did not have the navigation role, and so I was excited to find that here at UNC, and have just really enjoyed getting into the outpatient side of helping patients through their cancer care, and using some of the parts that I loved about inpatient in the outpatient side, and more developing that more fully.
Great. Well, we're very fortunate to have you as well. And I know that, let's take a look. How did our audience do with the question?
Good job, guys.
All right. So they're on target. They didn't go off at all.
So this means I should just skip forward in our, because you already know.
We're done.
Right.
Yeah. No, but I know they've got a lot that you have a lot to offer, and we don't want to hold things up anymore, so we'll jump right in. And we have this mouse in case you need to use it as a cursor and point at anything as well.
Wonderful. Thank you. Thank you very much, and thanks you all for listening, tuning in, and helping us get the word out about navigation and navigation needs. Our topic actually is working with patients with complex needs, and I think as everybody really understands, the setting in cancer care is getting more and more and more complex as things are moving out from inpatient to outpatient. We have to learn to specify needs of the patient, but also of the patient's family and those designated caregivers. I think nobody is surprised when we get a diagnosis of cancer that everything that we've ever known, everything that we've ever thought we knew, flies out the window, and things can kind of stall for that patient emotionally and mentally. But obviously not physically. So we need to develop these things to keep moving. So I'm going to hit this button, and I'm not sure. I knew it wouldn't.
Oops, that's all right.
There we go.
There
Sorry.
we go.
Thanks, guys.
Oh, no worries.
So as we know, cancer has not always been a patient-centered process in medical care at all. Cancer care has often been a surgery, and then things are taken care of. That was true for breast cancer about 20 years ago. It was a mastectomy and maybe a little bit of a chemotherapy that we knew was going to work. But as things have evolved, we know that our system has to evolve. So what we have seen as things move to the outpatient process is that cancer has not always been the patient-centered process that we have and are working on today. There are wrenches thrown in from every angle. You have patients now who have to drive 100, 200, 300 miles to their closest cancer facility, or they are going to have to decide if they're going to do treatment or they're going to buy their kids tennis shoes. It comes down to the fine art of living if you are given a cancer diagnosis. So just a little bit of history. 1990, this all kind of got started with Harold Freeman, and we know that whole process, but it wasn't until 2012 that there were different medical organizations who really took a look at navigation for those cancer patients. And what they had known from Dr. Freeman's efforts is that we really needed to get cancer patients engaged in their own cancer care. There was a huge discrepancy in lower income patients getting the care that they needed and actually having the ability to follow through with cancer cure process or cancer treatment processes. We knew that there was a lot of need for some specifically trained people to be dealing with these folks. There has been more centered thought with cancer care through ONS. Some of the specific types of organizations we have, like ONS, the Oncology Nursing Society. We have been able to train nurses to specific disease processes within the cancer world. And through that, as most of you know, we now have evidence-based cancer care. One of the things that was put forth by a couple of presidents, and several since then, Ronald Reagan was one, who signed into being for us that those centers who wanted to be designated cancer centers had to specifically put forth a program that would help these patients be able to know what they were being treated for, how their cancers were going to be treated, what they could expect if they needed outside sources of financial considerations or transportation or anything that you could possibly think of, that these specific persons or individuals called navigators were going to be the ones who were going to help make that happen. So 2012, we also got on board with some goals of recommendation, and as you look at this slide, you can see which ones actually say navigation. I mean, so what we wanted was somebody who had the knowledge, the training, the ability to be consistent from cancer diagnosis through the whole continuum, whether that was to become have a new normal at the end of their treatment, or at the end of life consideration. And those people actually became nurse navigators. So ONS, the Oncology Nursing Society, put out a joint statement. They were considered with, excuse me while I look for 1 minute, with the National Association of Social Work and Oncology Social Workers and the National Association of Social Workers got together. They put together a nice statement that says what patient navigation is, and it says everything that we have always wanted to be: cancer care, individualized, offered to the patient and the family and their caregivers to overcome any kind of disparity that they might face. This was revamped in 2013, and it stands as is. There is a difference between oncology social work and a difference between an oncology navigator, and the biggest piece of that is that the nurse navigator is going to be someone who has been specially trained in cancer care. We can't do our jobs without our social workers, so that's where we start looking at a team approach. Navigators are going to be a BS trained nurse. They're going to have that specific clinical knowledge. At UNC, of course, and several other areas, we have dedicated disease process navigation. We're a pretty big facility, so we kind of have to do that, and we have to rely on our knowledge to help these patients traverse through this whole cycle. We are to help overcome system barriers. From the very beginning, we are to do assessments, and we should be doing assessments to find out exactly what those needs are for these patients, and providing them, along with our other team members, the kind of care that they need. The Oncology Nursing Society has been putting out roles and responsibilities for nurse navigators, and we'll talk about those shortly. As we know, there are many benefits to having a nurse navigator. We not only, Jacqueline alluded to this earlier, we not only educate our patients and our families, but we educate each other, and we help the entire team understand what this patient is going through and who this patient is and what their specific needs are. We, as navigators, start at the very beginning. Our surgical navigator here meets almost every single patient who walks through the doors, and it's a huge assistance for that particular patient and the family to know that there is someone sitting there listening to the things that they need to have. By the time they come to medical oncology, they've had a little taste of what their treatment is going to be, the overwhelming sense of what's next and who's going to provide the information for that. They understand that there's going to be somebody there for them. We as navigators don't just spend our time in one facility. We sometimes have to coordinate that care between facilities, and it's very helpful to know who it is that we need to call to get things arranged and have things done in a timely manner. I always, when I look at this slide and I see the very last one that says provide emotional support, I think that is the one thing that, above all, we need to help these people get from their physical encounters here to the next place, but above all, emotional support for these patients is one of the reasons why I think we're here. As nurses, we're trying to treat the whole person. We may not write those orders for chemotherapy, but we sure have to know what that chemotherapy is going to do. And sometimes it's the navigator that makes sure that patient is going to get to the end of that treatment. So as I said, roles and responsibilities have been talked about, thought about. ONS and social work and several different entities have kind of laid out for us what a role for a navigator should be, and I think they all collaborated pretty well. I think everything that you see on this slide speaks to what navigation truly is. We are coordinators. We are sometimes the Olivia Pope of medicine, because we do need to know everything that happens, where to send these people in the hospital, how they get there, are they supposed to be NPO for a specific test. But each one of the steps that we take with these patients is individualized. It's not a blanket therapy for each patient. This is one of those slides that you really don't have to read. You really just have to look at it and understand that this is just a smattering of what navigation is, what we do and what we are happy to do. We are truly a multidisciplinary member of a multidisciplinary team, radiation oncology, surgical oncology, medical oncology, the chaplain, the financial aid people, pharmacists. It's just, we have to have our finger on everything that goes through. We, again, may not be the person who is actually doing that treatment, but we are making sure that it happens. One of the things that I did want to, we have to have some scientific proof of this, and we can't actually measure scientifically what navigation adds to this big pot, but what we do know, and this is information coming from the Medicare people is that when we treat people with chemotherapy, if we don't educate them and if we don't educate family members, those people are at high risk for coming back between visits, ending up in the hospital. It costs them, it costs us, and in today's medical management market, that's pretty expensive. This slide had information from 2011, $26 billion a year. And so that's a huge part of what a navigator does. We try to keep our folks out of emergency rooms and out of being readmitted to the hospital, and we do that by education. So this very busy slide here gives a nice goal of an oncology care model. I think the biggest thing to point out here is that there are not just huge hospitals that have these or using these care models, but the standalone oncology offices who do give chemotherapy, do radiation treatments. Those folks also are finding that navigation is helping them cut down costs, but also they are able to take part of a navigation system. They are finding, these standalone facilities are finding that they are better able to help a patient through the cancer continuum. Doesn't have to just be in a large hospital. We're seeing more and more nurses turning to navigation in that smaller facility. So one of the things that we wanted to do after we got finished with giving you a little bit of history about navigation and what we do is present a little bit of a case study, and Jacqueline's going to do that for us. I'm going to pass the baton.
Thank you. So we're going to talk about Miss Sarah. She is a young lady who found what she thought to be a mass in her breast. So she saw her primary care provider, and this was confirmed that she needed to have a mammogram. And the mammogram reveals that she does indeed have a mass. There's also, by ultrasound, found to be a mass in her axilla. So biopsy is performed and cancer is confirmed. She's got breast cancer confirmed in the breast and in the axilla as well. So the patient is informed, and at that point she's going to meet her oncology team. And I find that sometimes patients don't know that the team means that they have more than one oncologist that they see, especially in a big facility like here. They have surgical oncology, they have their medical oncologist, they've got a radiation oncologist. For this patient, she's very young, and so genetics is also probably going to be involved. And here is a teaching point right off the bat. The navigator often comes in right from the beginning and introduces themselves, and we can talk about what to expect, or who. I thought I just saw an oncologist, who am I seeing now, and explain that this care is specialized, and that's why you have a navigator, so that we can help you with those questions and help facilitate care as you go along. This slide talks about what all the navigator does, not what all the navigator does, a piece of what all the navigator does. So let's look at it from the beginning. When you meet a patient, you're going to be assessing their needs. For Miss Sarah, she lives alone. Does she have social support? Does she have family close by? What about financially? Does she need support in that way? And this assessment really continues throughout the patient's care. And the things that the navigator can help facilitate for them are often based on, what their life situation is, not just what their cancer diagnosis is. So we look down through patient needs to have chemotherapy. So the navigator can facilitate having a pharmacist speak with them about the specific agents, but the navigator is also going to spend time talking to them about side effect management. What are the side effects that you can expect? How do you deal with them? And then, they may need some support emotionally or mentally. We have a great cancer support center here, and often patients need, they need the navigator support, but there are many patients who need ongoing support more than the education pieces and coordination that the navigator puts forth. And so you can set them up with social work for outside resources, set them up with a counselor if needed. Maybe the patient has children that they're concerned about how to talk to them about this new thing in their lives that's kind of disrupting everyone's life. Then, at any point, for the support, it may change throughout their cancer care. They may be fine in the beginning and doing very well and then hit a low point. As nurses, we assess and reassess, and that's the same in nurse navigation. Also, patients will bring paperwork. They may have disability paperwork, FMLA paperwork. These are things that we can help get done for them and help things go smoothly with their work situation. These patients require lots of imaging, staging studies. Maybe they need to have their cardiac function monitored or assessed in the beginning. They're going to have various procedures. We have on here port placement. I find that patients like to see and feel and talk about that beforehand sometimes. It's, what does the port look like? What does it feel like? Where do they put it? And how do they put it in? And that is something that we can offer to them, is that time to sit and talk through things and take each of their questions and reassure them. They have a new schedule. Their cancer care requires a schedule, and we can explain that to them and help facilitate getting what is the most convenient for them in an inconvenient time. Then we go back to side effect management. So they start their care and they start experiencing some of these side effects. Some patients will call you many times because they don't know and they're nervous about this pain or that feeling. Some patients won't, and that is, the navigator can see, does this patient need me to reach out to them because they're not a complainer or they're too scared to ask? And that's also part of their emotional support. So, the patient's going along in their treatment, and then, oh, look, you find out that they canceled all of their follow-up visits, even though you've gone through the schedule with them. And you realize, maybe the patient thinks that I'm feeling great and I don't really need the next appointment, or they take a trip, and so they just decide that they're going to cancel the next few appointments. So there's another follow up with them, talking through, okay, yes, you do actually need these appointments. It's very important for you to follow this schedule, and getting them back on track and reassuring them and re-educating them. So then we come back to side effects. Maybe they did miss an appointment and they call with some urgent concerns, and so you go back to maybe it's new side effects that they're dealing with. And I like this slide because it kind of, we're saying some of the same things over and over, but it's because this is what the patients need, because this is something new in their life that you're there to help them understand, yes, this is normal, or no, we need to check this out further, and to help them understand these things. We go on, if they have surgical management of their cancer, they like to know what's going to happen before, during, after surgery. What kind of side effects would they have from radiation treatments, or are the things that I'm experiencing actually side effects of my radiation therapy? What can I do for them? It may be a matter of skin care and those sort of things, and you can help them with that, or put them in contact with a person who's going to be able to specifically care for those needs. More follow-up. Unfortunately, not every patient has smooth sailing through their cancer care, and they may be admitted to the hospital. And, you know, if you're in the same facility, you can make that contact with them while they're there, but making sure that afterwards they get back on track with their follow-up appointments. Maybe rearrange things, move an appointment out, and, you know, we don't direct their care while they're inpatient, but just being aware of their status so that once they're out of the hospital, they can get back on track and get back into the schedule that they need. We don't like to see poor outcomes, and there are things that can affect poor outcomes. It's our job to minimize those. So as has been mentioned several times, communication is a big piece. And this may be communicating with them or their caregiver, giving them the right education ahead of time or during a situation. Not every patient is compliant with their plan of care. A lot of times they're more compliant if they understand and we've helped to tell them up front or help them along the way. They don't all have great resources, but we can put them into contact with those things. And that's one thing that I find that's great here at this facility is the amount of resources that we can offer to the patient specific to their situation. And we always want to be using evidence-based care and giving them the best that we can in their cancer care. Moving on, we as navigators want to target high-risk patients. You can see here listed that may be a metastatic patient or a patient with neurologic symptoms, patients that have not as much social support as we keep bringing up, or their functional status maybe has declined during their treatment. This makes them higher risk or one that we should be flagging to kind of keep an eye on and help them through, because these things complicate their care, and that's where we come in and can help them and facilitate the smooth providing of care. And we want to begin concluding. All of our cancer patients, we want to have the highest quality of care. they have a lot of needs, not just one specific need, but this cancer brings in so many different aspects. It affects their whole life, and we want them to have high quality of care and not to fall through the cracks, so to speak. It's our job to help them along. And I believe with navigation, it's found that patients have a better experience with their cancer care because they have that support. As was just mentioned, we want to pay special attention to those that are at high risk as their cases are more complicated. Just because their cancer care has become more complicated doesn't mean that they have a better understanding of it, and that's where we can help them. A team approach is huge, that multidisciplinary team, and also using not only nurse navigators but lay navigators, maybe just to help them when they come for appointments and getting from place to place. Lay navigators can also help with the communication piece and be someone to talk to and kind of minimize the barriers of, I'm in a big facility for my care and I don't know where to go, or I don't know how this works. Often the lay navigators have some familiarity with cancer care personally, and they can help with those barriers as well. So do you have anything to add, Amy, in conclusion?
No, I think we are ready for some questions if we...
All right. I hope we have lots of questions. I just want to say thank you to our audience. We have a large audience today, and we can see a lot of rooms around the state with clinicians and looking very interested in this topic. And so if you can pass me the keyboard for just a moment, I'll just remind everybody of how to submit those questions. It's very easy. We've got your literature review here, continued. So the easiest way to do this is if you already joined Poll Everywhere earlier, then you're set and you can just text your questions into us. If you didn't, one time you text 22333, text to that number 22333 with the letters UNCCN. That joins you. Then you can go ahead and start texting your questions. You can also go to pollev.com/UNCCN and you can get us your questions that way. So we'll look for those questions. I have lots, so but I know that you have questions in our audience too, so we hope you'll start sharing those. Let me jump in with one. Our last lecturer was Dr. Ethan Bosch, and he talked about patient-reported outcomes. And right after that lecture, then he had a nice write-up in the Washington Post talking about that work and the efficacy of that work. What are you it seems in some ways you all might be the recipients of the lion's share of the outcomes, that there are scenarios where patients might be most likely to either face-to-face or in a call to report those outcomes. How are you starting to intersect with, say, the work Dr. Bosch is doing in terms of maybe some of the automated processes, using smartphones, et cetera, to report patient outcomes?
You want that one?
Go ahead.
So, I like to talk. So, one, if I'm understanding the question correctly, one of the ways that we can add to the information that Dr. Bosch is working with is by being able to appropriately assess and then report through our EMR.
Great.
Which is something that is also part of the regulation that you have to have a Navigator program.
Right.
But the relationship between the Navigator and the patient is usually far different than it is between the patient and the physician. So we have to be that link, and we always report the successes. We have to figure out what doesn't work as well.
That's interesting, and one of the things we talked about is what is is there a level of hesitation on the part of the patient to report certain things? Because not only do they want to be having a successful treatment, but in a way they may feel some sort of sense of responsibility for the clinician, that they want the clinician to be successful as well. So is it possible that you in a slightly different role, in the role of navigator, hear some things that other clinicians may not?
So interesting that you asked that question, because just this morning I was speaking with a very knowledgeable patient, very intelligent patient, who actually verbalized to me that the questions that she really wanted to ask the provider, she was afraid would be too disrespectful.
Oh,
So,
interesting.
and didn't want to take up the provider's time.
Interesting.
So my first thought was, that's why we have navigation. But the second thought that I had was, even if you are present in the room, which sometimes navigators can't be because of the different details that we have in our care, everyday care, but even being present in that room sometimes gives that patient the feeling of being brave enough to ask that question. They feel like the provider doesn't need to be burdened with.
Interesting.
Even if it is specific care,
Yeah.
So.
I think that is part of our role, is to encourage them. Sometimes if you get in a room before the provider, or maybe you have contact via MyChart or on the phone in between visits, patients will bring up questions. Well, I don't want to bother the provider, or I don't know, I'm not trying to be disrespectful, or they might say something like that. I've heard that a few times, but I think encouraging them to speak up, and yes, that's an important question, and it is something that you should speak with the provider about. We can kind of be their cheerleader, or encourage them that this is your care. This is not the doctor's care. This is specific to you, and you. It's perfectly appropriate for you to speak up. I enjoy that part of encouraging patients, that it's specific to you.
That's great, and that's powerful, because we know increasingly through research that not only is it important for people to ask these questions, but ultimately it has an impact on their outcomes.
That's correct.
Yes.
All right, well, I'm glad to see we've got questions coming in. What do you find the most challenging part of your role? So for each of you.
So one of the biggest challenges I think that I have faced in the 6+ years that I've been doing this is not having enough time to do all of the things that I know that this patient needs to have done, to be able to reach out and to each one of these patients and almost just, it's almost just a touch. I just need to touch these patients. But once the patient is rolling, and because we do operate on a multidisciplinary type of care, cancer care, it's almost too difficult to keep up with what that patient needs from each one of the entities that they're involved with. And so that's a very frustrating part of navigation. Sometimes leaves me very sad that we weren't able to do more.
And given that, and that in so many professions that's a restriction, do you find that there are certain things that, looking back, you say, well, given that I didn't have enough time to do all the things I would have wished to, what were some of the things that had the most impact, given that limited amount of time?
I think the things that really are most impactful is assuring that patient that no matter how many times they have a question, and even if it's the same question, that they have to ask these questions and they have to convey to their family members. There are so many patients who say, I don't want my family to know about this. I don't want to bother anybody. So on the most sad times, it's having to sit with a patient that I know is not is going to pass away from her disease process, and having to explain to the family why they're just now finding out. It's very, very sad.
Jacqueline, what about for you in terms of that most challenging part of your role?
Well, I was going to say something very similar, that it never ends. There's, most of my experience before was inpatient, and so you finish your shift and you finish your tasks and you pass on to the next person, next nurse. In navigation, you continue with that patient. When you leave at the end of the day, the job is not necessarily done. Every bit of paperwork or every question is not answered. And I think that the way that you combat that for the patient, or cause it to not increase anxiety for them, is the communication piece, and assuring them that, yes, we're working on this, yes, I'm communicating with your doctor, and that is it's been helpful for me to realize that at different points, that as long as there's they have that open line of communication, a lot of times that's helpful in minimizing the stress for them, and for the navigator to realize I am trying to get as much done for this patient as I can to facilitate things and make them smooth for them.
Yeah, I think that can be very empowering. It's can be such you can lose so much power, perception of power as a patient, and being able to know that you have somebody on your side who's being proactive is very significant.
Yeah.
We have other questions coming in. Thank you. Keep those coming, please. How does UNC help smaller cancer centers, cancer center navigators, coordinate care? So obviously this is really significant here at UNC, within UNC Healthcare. What kind of mentorship role are we playing with other cancer centers?
Well, so I think that one of the ways that we're helping, I don't think it's we are accumulating smaller hospitals. This is 2017, and so we one of the things that we do have is a director of outreach program for navigation, and so we do here at UNC do a lot of mentorship for some of those smaller facilities. We try to do as much conferencing education as we can. We have navigators who do present at national conferences, and we do, but even here in our state of North Carolina, there are outreach. Gene Sellers, our director, does a lot of outreach with those people.
Great. And Gene Sellers is also part of the UNC Cancer Network team.
Yes, she is.
All right. Jacqueline, anything you would like to add to that, or should we go on to the next? All right. Okay, so how many navigators do you staff, and are they site-specific?
I am not quite sure exactly how many we have. We've recently added a large number of hematological navigators. We went from, it seems to me, we went from 2 to about 6 in a very short amount of time. All of our navigators, with the exception of the CCSP navigator, who touches all of our patients and all disease processes, but we do, all of our navigators are site-specific here at UNC. We recently went from 2 breast navigators to 4 breast navigators, and one of them is specific to surgical oncology for breast.
Okay. Another interesting question coming up. Do you feel the navigation role could be held by an allied health provider, i.e. managing technologist, or should it only be an RN?
Well, I can speak a little bit, and then you can. I think that it may depend on, here at a big facility, it's helpful to have an RN, because you do a lot of side effect management, specific to the disease process or to the medications or their regimen, chemotherapy regimen, that sort of thing. It might be at a smaller place if it was not disease specific, could be a little broader. But when you get down to disease specific, it's very helpful at the least to have an RN. We find that as we deal with protocol patients and that sort of thing, that a lot of their care is managed by the protocol coordinator and often needs the input of a nurse, a registered nurse. And so I think that's very helpful at the least.
Yeah.
Do you have anything else?
Well, just to add that when navigation back in 1990 something, when Dr. Freeman was first using navigation, all of his navigators were lay navigators. They were people from the community who knew the community and would reach out to those folks. And as navigation has grown, one of the things that has to be presented for those cancer centers who want to be known for their specific type of care has to be a registered nurse navigator. The lay navigators are very useful in helping, just as Jacqueline had said earlier, in helping to get people from point A to point B or what have you, or even just being another person to speak to. Mm-hmm. But the reality is we are known as navigators, but every person in our team, from the imaging tech to the PharmD that sits with the site-specific clinics here, the infusion nurses, all of us, that's not by all means any of the whole team, but all of us are acting as navigators at one point in time, but specific to cancer care, this needs to be an oncology certified registered nurse.
Okay, thank you for that clarification. Here's another one. What is the navigator role with survivorship?
So, survivorship has become the new piece of cancer care that we all need to be really aware of. Mm-hmm. We tend to think that survivorship starts with the time of diagnosis. Mm-hmm. So automatically you're a survivor. You're going to be a survivor. We have a survivorship program here. There is not much change as far as somebody who is 5 years out or 10 years out who needs to have somebody direct them where they need to go. We don't automatically turn it off just because they are no longer in active care. So that survivorship is developing. Mm-hmm. Mm-hmm.
Good. What is the future of navigation, and how do you prevent burnout in your program?
I think the future of navigation is that it's going to continue to grow. I think the different levels of navigation are going to continue to grow. They certainly are beginning to here. Burnout is something that comes in two parts. You either have burnout from your role as a navigator, or you develop compassion fatigue, which in the life of an oncology nurse is bad. It can happen. Mm-hmm. We have to recognize it. We have to acknowledge that it is here, and those processes have to be set in place because it's all part of the education for all of us. Mm-hmm. At UNC, we have folks who actually do a weekly burnout / compassion fatigue program. Mm-hmm. We take about 45 minutes and we do some preventative measures.
Good.
To help out, because we're all here because we have this desire to help, and so we can't let that go. Yeah. We have to stay true to the course.
Absolutely. All right. Looks like we've got about 5 minutes left. We have time for, I think, if to take these two last questions and then wrap up. Have you considered adding mental health care providers as well as a hairstylist and skincare professionals to your team?
We have them.
You have them. Well, you have considered that.
Yes.
Sounds like a yes.
Yes.
Our CCSP team actually has classes for our newly diagnosed folks going through chemotherapy or even out of chemotherapy. So yes, we have those connections and we use them a lot.
Yes.
Good. And can you please expand upon the variation in roles and responsibilities among patient navigators and social workers and financial care counselors?
Sure. If they need resources in the community, a lot of times we're going to refer them to social work. If they have specific financial needs, help with their bills, we might put them in contact with the financial counselor to talk through those things. If it's insurance specific, that sort of thing, the financial counselor can look at those specifics and help them through that. Social work, I just kind of simplified that, but we use them. You want to speak a little bit too on that? Out in the community, the social workers, I find when I bring them in, they have a lot more knowledge than I do about the community resources, the support groups or the transportation helps or home care types of, not facilities, but providers. And it seems that the navigation role is putting the patient into contact with what is specific to their need. And I think in the past it has done more of the social work role possibly, but as it grows, the navigator can identify that, yes, I can help in this, but it would be better if you could get more information and more specifics if I put you into contact with the social worker. Do you have more?
No, I think actually that is one of the written differentiations there between the navigator and the social worker and the financial care counselor is that they are specific needs. We are more, the nurse navigator is more relegated to medical care. So, we're the side effect management people, among many other things, but we all have to have help.
Well, Amy and Jacqueline, we want to thank you both for all the great work that you do, for your time here today and your expertise. If you heard this lecture and want to hear it again or want to tell somebody else about it so that they can see it, you can go to our site at unccn.org and find the recording of that and almost 190 other lectures, including the one that we referred to a little earlier today with Dr. Bosch about patient-reported outcomes. We want to not only thank our guests, we want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund, or UCRF, and UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, our operational coordinator, Veneranda Obore, our AV support engineer, and Alan Brown, our continuing education specialist. By the way, if you want to receive our newsletter, you can send us an email at unccn@unc.edu and let us know. Mary King is our newsletter editor, and she'll make sure that you regularly receive those monthly newsletters. Both there and at our site, you can find out about all sorts of upcoming events, including on June 28th, our medical and surgical oncology lecture, Treatment of Relapsed and Refractory Multiple Myeloma. On June 30th, our community lunch and learn lecture, Understanding and Living with Chemobrain. And on July 12th, RN and Allied Health lecture, Distress in Older Adults, Why Should We Care? What should we do about it? So lots coming up. All of our events are under the events section on our website. Again, email unccn@unc.edu. You can call us. You can find us on the web, Facebook, Twitter, YouTube. So thank you so much. We really appreciate this.
Thank you.
Thank you to our audience. We'll see you next time. Take care.